let me welcome on behalf of Occult to a program called Beyond Boundaries. It's a webinar series by Occult. We welcome Dr. Arnab Karmakar, who is an associate professor in IPGMER and SSK Hospital, Kolkata, which is a premier teaching institute in the country. He has completed his fellowship on arthroscopy and arthroplasty from Adelaide, Australia, who is also a consultant orthopedic surgeon in Kothari Medical Center Joint and Bone Care Hospital, and also presently executive committee member of West Bengal Orthopedic Association.
Sir, is hand over to you. I am stop sharing my this thing screen.
And I have just 30 seconds. I'll request all the participating doctors to put their questions on the chat box. Dr. Arnab will attend all those questions after the deliberation.
Definitely.
We will take all the questions. Whatever your queries, we will take all the questions. And I think Dr. Karmakar will definitely give the answer of your questions. So please put on the chat box, and we start. And once again, from behalf of OCAD, welcome, Dr. Karmakar.
Thank you so much, and I thank you, CARD, for taking this thing going forward, because teaching should be continued, and this scientific data and this knowledge should be shared with all, as many as people. And as we are not able to go out and do the conferences and meet people, so I think this is the best way we can continue the sharing knowledge. We can share with the participants, we can share with the people. And the beauty of this type of webinar is that there is no logical boundary. So anybody from any place of the country, or even from outside the country, also can join, can share their thoughts. So the motto of this thing is to share knowledge and how people are doing, and so that we can improve our skills. Everybody should learn something from this type of meetings. So I once again thank you, Khad, so for doing organizing such beautiful webinar. So what we'll do and discuss today is that our main motto of today's discussion is the basics of arthroscopy. So what is happening nowadays is that a lot of webinars are going there, here and there. So every organization and every participants are going through many of the webinars, but lot of or most of them are actually based on this advanced discussion. So I thought I should go for some basic discussions which will actually help the new or budding surgeons, or the PGTs, or the trainees who are actually going to start their arthroscopy. So in the first half of my lecture, I will take you through what are the basic points of arthroscopy, what are the practical tips and tricks of arthroscopy, so that you can be we can help doing that. And after that, I'll share some of the important points regarding the anterior cruciate ligament, its anatomy, what are the things we should keep when we are planning for doing an anterior cruciate ligament reconstruction. And if time permits, we can show you some of the practical tips and tricks, and few small videos of intraoperative videos to make you clear. So I'll start with this basics of arthroscopy, and my request to every participant is that please put your questions in the chat box. I ensure that all of your questions will be answered. I'll attend every questions, so please put it in the chat box only. Thank you so much. So let's start with the basics of arthroscopy. I hope my screen is visible. Fantastic. So we'll starting with the basics of knee arthroscopy. So to understand what are the indications of doing a knee arthroscopy, we should be very clear about where we are actually going to put our scope, because the surgeon's principle always remains that we should do no harm. That is important. We should do no harm. That is very, very important in that scenario. So first and foremost, important indications of doing a knee arthroscopy is that some of the times, in some patients, there is a different type of clinical features, which is in MRI findings is not always matching with that clinical features. So in that cases where the diagnosis is still not confirmed, we can do a diagnostic arthroscopy. But due to the efficiency of MRI nowadays and availability of other investigations, these indications are actually coming down. Then removal of loose bodies can be done through this diagnostic arthroscopy. Synovial biopsy or synovectomy can be taken to this knee arthroscopy. Meniscal repair or meniscectomy. One of the most and important indication for knee arthroscopy is the ligament reconstruction surgeries like anterior cruciate ligament and posterior cruciate ligament. So these are the two commonest ligaments which we can reconstruct by doing knee arthroscopy. There are many other, so we'll go with this. Then repair of some chondral defect or some cartilage defect, including doing a microfracture in case of a cartilage defect. Then removing a dead piece of cartilage from the joint, like in some disease like osteochondritis dissecans, and knee debridement for osteoarthritis. That is a controversial topic, so I'll not go into that, but there are few specific indications where we can treat this osteoarthritic knee with knee debridement. So these are the per se all indications for which we can go for a knee arthroscopy. What are the prerequisites? What are the important instruments we should require for doing a knee arthroscopy? That is must, because each and every instrument is important, and you should acquire, you should know, you should have clear idea of all of these instruments. Otherwise, intraoperatively you can be trapped in a different scenario, and it will be then very difficult to bail out in that from that scenario. So arthroscope, it may be of 30-degree or it may be of 70-degree. Fiber optic cables, which is actually passing the fiber optic cables, which are actually passing the light from the light source to the arthroscope, which is actually important. Light source or the machine is also important for the light to produce. Accessory instruments are there which can help doing this procedure. Television camera system is there. Probe is also very important to examine things, to measure things intraarticularly. Scissors to cut something within the knee joint. There are some basket forceps or punches which is to go for meniscectomy or remove and cut any of the intra-articular tissues. These basket forceps and punches are very, very important. Then some grasping forceps are there to grasp something and to pull something. Knife and blades are there, and motorized saving system to take out all the debris within the joint and fat pad to clear the joint, to clear the visualization of our joint. It is very important. Finally, electrosurgical laser and radiosurgical or radio frequency ablation. But in case of knee arthroscopy, it is not that much of useful, or it is not that mandatory, whether it is more useful or mandatory in case of shoulder arthroscopy. One by one, but you should have a clear understanding of everything. You should have to know. Second point is that after doing all the instrument, you should have clear knowledge about all the instrument, and this is the arthroscopy tower, and you should also know how to regulate, how to maintain all the arthroscopy towers, because this is also important, because every point is important. So there is usually a monitor which usually controls this arthroscopy. You can have the visualization in the monitor. There sometimes there has been a second monitor so that some other person can have a control on that. And the light source and the camera unit. So this is the light source and the camera unit. So basically it is there from where you can have control the amount of light or amount of uh, brightness or zoom in the camera, and even you can do the white balance of your camera. Then is the power box or motorized shaver system. So you can have change your speed of the shaver from this. Sometimes there is a foot control of the shaver, sometimes that can be controlled from your hand only. Irrigation pump is required for shoulder surgeries, not very useful for knee surgeries, but sometimes may be required for a meniscal procedure. Power box or radio frequency, as I already told, it is important for shoulder surgery. Sometimes some units may have facility of printer so that you can take snapshots and give show it to the patient with their discharge paper. That is also sometimes provided with some of these features. So next you should have understand how this connection occurs, because you need to set up all these connections properly. Otherwise you can be in trouble within the operation and you have to fix it by your own only. So these connections, first is important is that, so there is a monitor and a power source. So this camera unit and light source unit is attached with the power source. Then this light source is attached with the arthroscope, and this camera module which is connected to the camera system you attach the arthroscope to this camera module. So first you attach the arthroscope to the camera module, then you attach the light source to the arthroscope, then you put the trocar and cannula, and you put the arthroscope within the trocar and cannula, and one side of the trocar you connect the fluid or the TURP set or fluid irrigation set, and opposite side you can put you can connect a sucker tube if it is required. So you should have a clear idea of the connection of this tube. That is very important. Are there, so you should have also a clear idea about how a arthroscope functions and what is the importance of having different angles of arthroscope. So most commonly used angle we use in case of knee arthroscope is a 30-degree of arthroscope. So in a case of a 0-degree arthroscope, you can see on the image on the left hand side that in case of 0-degree arthroscope, the visualization area is limited. We will have a central round vision. Whereas in case of a 30-degree arthroscope, the visualization area increase many-fold, and when we can rotate it, we can actually have many areas into our vision. So now you see the image on the right side. The first image is the arthroscope which is 0-degree. So it will have a vision which does not change even if you change the arthroscope or rotate it. But in case of a 30-degree arthroscope, you can see that the circle or the visual field increases, and by increasing or by changing different angle, you can actually look at different places within the joint. And at 70-degree arthroscope, the visualization area increases many folds. But in cases of knee, we don't require this much of arthroscope. Sometimes it is required for larger or circular joints like hip joint. So for knee, we'll stick to arthroscope, which is having a 30-degree angulation, because it is have a very good and visualization. And by rotating the arthroscope, we can look into many parts of the joint. So that is important. These are the trocar, and these are the two types of trocars are there. One is a blunt, one is a sharp. Within the cannula, then we put it inside. Then we remove the trocar, then we put our arthroscope. So this arthroscope has got one area to attaching the light source. So this blue part should be mounted to the camera, and this other area where we should actually put the light source in. Most important and the second most important instrument which we require in case of arthroscopy, because we need to probe everything, because it acts like our left hand which is placed intra-articular or extension of our hand, which we can examine many structures like meniscus, whether it is intact or there is tear in the undersurface. We can pull the ACL or PCL ligament to see whether it is integrity is maintained or there is some intra-substance tear. We can examine some cartilage flaps to see how it is attached with the subchondral bone or it is loose. And also we can measure many things intra-articularly. You can see there are markings in the body of the meniscus. So by this marking, it can act as an intra-articular ruler also. So these are the benefits of probe. And this tip of the probe is actually 3 to 4 millimeter. Most commonly it is 3 millimeter, but it can vary from company to company. So by putting this probe, we can measure the thickness or diameter of a meniscal tear or injury or a defect in the cartilage area, that it is 3 millimeter or 6 millimeter or something like that. So this is a very useful instrument. You must have this instrument. Without this, knee arthroscopy is not possible. Next comes is the grasper. As I already told, these are all grasping devices. This can vary depending on the many types of their tooth they are having. So usually commonly this is useful for holding something and grasping and pulling it towards yourself. And this is also a very useful instrumentation. Next comes, as we told, all the punches or basket forceps. So these are to cut the part of a meniscus, or cut a loose ligament fragment or cartilage fragment. So this comes in various sizes. This comes with various bends, like bend towards left or bend towards right. And sometimes there are meniscal scissors also. So all these arthroscopy scissors, you can cut some part of these meniscus also. So these are all cutting and punching devices. These are all required for your meniscectomy purpose. So you should have a clear idea of this. This is a shaver system. So usually it has 2 or 3 parts. So it's the shaver control unit, and there is a hand unit where the shaver blades are attached. Different type of shaver blades are available. You have to attach it. This varies in size, like 4.5 and 3.5, and sometimes there are associated bar option is also available to take out some part of bone or loose fragment of osteophytes. Sometimes these bar are also very useful. You can control the speed, and you have to attach the suction pipe at the back portion of this shaver. This is a radio frequency ablation machine. So different types of radio frequency ablation probes are also there. 0 degree, 90 degree, 30 degree, different depending on the cutting ability. You can increase and decrease. This is mostly useful in case of a shoulder surgery. In knee surgery, sometimes we can use it in PCL surgery where we don't want to use the shaver. So next comes important thing is that the portals, most common portals for doing a knee arthroscopy, you have to understand and you have to know exact location, because this is the entry to the knee joint. So if you make a wrong entry, all your procedure will be very difficult, and you will most probably you will be in trouble. You will increase much more time, which will increase the damage to the cartilage or increase the chances of infection. So your portals has to be very correct, otherwise you are in big trouble. So first on the left side image, you can see all the anatomical portals which are shown. So most importantly, our viewing portal is our anterolateral portal. So it is, you have to mark the anatomical landmark like the patella. So it's from the inferior surface of the patella. Roughly it is 1 thumb below and 1 thumb lateral. So there is a lateral soft spot of the joint. So you have to make a incision, and that is the anterolateral portal. And under direct visualization, after putting the scopes in, we actually palpate the medial subspot, the exactly reciprocate area on the medial side, and we put a needle. So anteromedial portal is done under direct vision, whereas the anterolateral portal is done blindly. So first we do the anterolateral portal, then we come to do the anteromedial portal. There is also a mid-patellar portal or central portal. So you have to go just and from the midpoint of the patellar tendon. There are accessory many portals like posterolateral, posteromedial, and there are superolateral, supromedial. These are the portals which is actually from the superolateral corner of the patella or supromedial corner of the patella. These are all not very required in case of basic knee arthroscopy or ACL reconstruction. Sometimes this posteromedial and posterolateral portals are maybe required in case of a PCL reconstruction. So now see on the image on the right side that this posterolateral portal or posteromedial, which is the commonest, this portal is also should be done under direct visualization, because just behind that is the neurovascular structure. So you have to be very careful. So you have to scope the posterior compartment of the joint, and then you have to do the posteromedial portal under direct visualization. Same as for the posterolateral portal. So you have to be very careful, but these are required only for PCL reconstruction cases or anywhere where you need to scope to the posterior part of the knee. Otherwise, for a basic knee arthroscopy or ACL reconstruction, these are not very much indicated. So you have to understand and you have to make sure that you are doing your portals in the right position. Next, what is the procedure step by step? So once you have inside the joint, I'll again clearly deliberate every points of it. So just we'll go through by the what is the mnemonics to go for that is that first we put the scope into the suprapatellar pouch. So we look for any loose bodies. We look for any plica syndrome or plica, and we look for patellar and trochlear chondromalacia changes. So we have to see the undersurface of the patella, and we have to see in the trochlear articular surface. Then we go to the lateral cutter. We look for loose bodies or look for osteophytes in the superolateral part of the femur. Then we go to the medial gutter. We look for loose bodies. We look for osteophytes. From the medial gutter, we graze our arthroscope, and then we enter the medial compartment of the joint from the medial gutter. Okay. So now we are on the medial compartment of the joint. So first thing we look for there is any tear or injury in the medial meniscus. Then we see medial and tibial chondromalacia, because medial compartmental osteoarthritis is very common. Sometimes a patient with a long-term or chronic ligament injury may have associated these cartilage changes. So we have to look for this. Then we go to the intercondylar area. We look for the most important thing is the two important ligaments there, the anterior cruciate ligament and the posterior cruciate ligament. Also, you have to look for some trochlear chondromalacia. And one other thing important is the shape of the notch. Sometimes in case of very few or some in female patients, in a short stature female patient, the notch is very narrow or it is like V-shaped. So in that case, we have to be very, we have to change it to U-shaped notch. Otherwise, there may be impingement in the ACL or sometimes there may be problem. Next, we have to go to the lateral compartment. We have to see the lateral meniscus, look for any tears, femoral and tibial articular surface. Always we have to compare. Then we have to go for the posteromedial compartment. Look for loose bodies, medial meniscus, posterior horn, or root tears, or any ramp lesion. Ramp lesion is a capsular meniscus dissociation, which usually happens in the posterior part of the medial meniscus, and usually it is associated with anterior cruciate ligament injury. Then we have to go to the posterolateral compartment, look for loose bodies, lateral meniscus, posterior root tear. So this completes a diagnostic confirmation or diagnostic roundup of the knee joint. So for basic step, we need to check all the areas. We need to go all these parts of the joint. So what are the things will look like when you are inside the joint like that? Most commonly is when you go into the suprapatellar pouch, you can see the patella above and you can see the trochlea below. When you come to the medial joint space, you can see this B is the medial meniscus, above A is the femoral condyle, and C is the tibial articular surface. So you have to look for this cartilage, meniscus. Again, one probe is visible there. So you have to probe the medial meniscus, you have to lift the medial meniscus, you have to look for the undersurface. Then at the intercondylar notch, you have to look for the ACL and PCL, whether how much tear is there and where from is the tear. Either it is an avulsion or it is a complete intrasubstance tear. You have to look for that. And other important is that whether there is any remnant of that ACL is there, because that will help in guiding us to putting our tunnels in that. So you have to look for the remnants. And finally, in a figure of 4 position, we go for to see the lateral joint space. So in the lateral joint, so we look for the lateral meniscus. We lift it up with a probe and look for the undersurface of the meniscus for any tear, and we look for the cartilage changes in the femur and the tibia. So once you are done, these are the most important areas. Now, some practical tips how to handle your arthroscope, how to handle your light source. This is very, very important, because I have seen many juniors that they sometimes held it with one hand, sometimes held it with the other hand, sometimes they move the camera, sometimes they move the light source. No, there is a proper way of doing this. And this is very, very important. And I'll ask every junior to give very much concentration on this area. So the arthroscope and the light source are made such a way that you can move both of them. So you can move the scope also, you can move the light source also. They are independent to each other. But so that is why people get confused. One thing is important, that you should hold your arthroscope fixed. So your scope and camera module should be fixed. You don't move that arthroscope or your camera module. So camera module should always face upwards. See, a orange arrow is there upwards. So camera module should always face upwards. Now you can turn your light source, which will actually turn your arthroscope and your vision. Need to move your right hand. Suppose you are holding your camera module with your right hand, so you don't need to move your right hand, just only move the light source with your left hand, which is shown in the picture. By only moving the light source with your left hand in a circular manner, you can actually look in different part of the joint. See on the image on right side above, so how actually exactly opposite we are looking. So if your light source is onto your left, your visualization and light is going actually toward on the structures to your right. So that is why you have to understand the anatomy and you have to imagine the anatomy in your mind. According to that, you have to place your scope with that area. You have to land your scope with that area with help of the camera module, and with help of the light source. By rotating your light source, you can see different parts of the corner. Suppose you are in the suprapatellar pouch area. To see the patellar articular surface, your camera module should look above. You have to hold it with right hand. With your left hand, you just turn your light source towards down, so that your vision and light should be to the superior area. So you will look towards the patellar articular fossa. Again, at the same position, without changing the position of your camera module, you just turn the light source to superior area, so that you can have a vision to the inferior area, so that you can have a vision to the trochlear surface. So by changing this light source or rotating this light source, you can actually see different parts in one single position. So camera controls your horizon, light source works on inclination, angle and view towards the opposite side. That is very, very important. This control should be there, and this is the first basic training you should try to have once if you want to do a good arthroscopy. So next is a position of camera and light. So there are few very examples where you can see, suppose in the first left image, you can see that it's in the notch in the middle part of the joint, and your light source is towards your left. So your vision will be towards your right. So you will have a look in the posterior part of the joint. On the right side, you are on the lateral compartment of your joint, and you're looking at the posterior part. So you are looking at the posterior part of your joint and lateral meniscus area. And the image in below, whether you are in the lateral part of the joint and your light source is towards your right, so basically you are looking to the medial compartment of the joint. So by looking to the medial compartment of the joint, you can have a look in the medial meniscus part, you can have a look in the ACL and PCL part from this part of the joint. So these two things you have to be very confirm, very ensuring that you are not guiding in a wrong area, or you are just moving both. So fix your one hand, try to move only the light source. That will help in orientation, and you can visualize all the anatomical structures by parking your scope in different areas of joint, and then by moving or rotating the light source only. That thing has to be practiced. So how next is how to hold. So there are different methods by which you can hold the arthroscope. Some people hold it by one single hand. They hold both the camera module and light source, but that is very tough, and that requires very much of experience. So the picture above, you can see the surgeon is actually holding both together, and maybe he is using his left arm to doing another job like a meniscal repair or meniscectomy or something else. So that is why he is controlling with his one hand only. So this is one manner, so that you can use control your light source with your thumb by rotating it to have a good vision during any procedure, or else you can hold your camera module with your right hand and you can rotate your light source with your left hand. This is the easiest, and I will request everyone to practice the below picture as when you are starting, because it is easy to learn, and as when you become experienced, you can shift to the first one. So next is a patient positioning. So what is important is that a arthroscopic procedure should be done at the tourniquet, because the presence of blood can hamper your visualization. So it's better to do at the tourniquet. Some meniscectomy procedures can be done without tourniquet, but you have to be very experienced for that. So for starting, I think we should always use tourniquet, and before positioning of your patient, you should have a high support that should be fixed. The arrow is showing towards the thigh support. And you should be very careful. You should make sure that this thigh support with this thigh support, it is at the proximal and middle third of your thigh, and they should be able to abduct the limb, they should be able to flex the limb, they should be able to hang the limb from the side of the table, and they should be able to make it figure of four position. So all these things you have to check. Don't just ask your assistant to position your patient, then you come back and you see that you are not able to put the limb in figure of four position, because that will make very much problem intraoperative. So those things you have to make sure then before you proceed for anything. Then you drape the leg properly and mark your portals. That is very important. Every time you always have to mark your portals, mark the anatomical landmark, mark the patella, mark the patella tendon, mark the tibial tuberosity, mark the joint line, and always mark your intended portals, which are the portals you are going to use. And after your completion of the procedure, you have seen how much you have used them, or whether you put them in proper position. So drape the limb very nicely, mark all your portals, plan your operation, and then proceed. Then only you could be of a successful manner. So important first is the putting your anterolateral portal. That is very important. So a few basic tips and tricks I will discuss, because these are the important things. So first, putting your anterolateral portal. So there has been a doubt that whether we should give a horizontal incision or vertical incision. So some people can use horizontal, some people can use vertical, but the problem with horizontal incision is that it is though cosmetically better, but if you have to shift your portal high or low, it is difficult in that case. There is a chance of shifting your portal high and low, I'll discuss in a later slide. So always keep a provision that you can shift your portal high or low. So that is why I think vertical incision would be better to start with. When you are experienced, then you can shift to a horizontal incision. So give a horizontal or vertical incision, and you have to be careful that your knife should be away from the patellar tendon. The cutting or sharp edge of a knife should be away from the patellar tendon, and above from the above, because if your cutting edge is downwards, then you can cut the medial meniscus inadvertently. So sorry, lateral meniscus inadvertently. So that is you should avoid. So your sharp edge should be above and should be away from the patellar tendon. This is the trick. So you cut your skin, you cut your subcutaneous tissue, you cut the capsule, you feel a loss of resistance. After that, you can use with your trocar and cannula and push. So next, first then you insert your trocar and cannula in the same direction of your skin incision. So try to go inside the joint space as you have palpated the soft spot. So through this soft spot, you have to go into the joint space. Once you are into the joint space, then you extend the knee and try to maneuver your scope between the trochlea and the patella. So gradually, while you are extending the knee, you try to maneuver your scope through the trochlea and patella. And be very gentle. Don't put it in a rush or don't push it forcefully. Otherwise, you may injure the articular cartilage. Then, once you are into the suprapatellar area, you then put your scope. And first thing to do is check your white balance, whether it is good or bad. If it is not looking good, take out the scope, do the white balance in the outside, then again put in. Then irrigate the knee, because sometimes there may have been a collection or effusion. The tissue will look yellowish or something like that. So you just put the saline, go in, and then stop the saline and the irrigation cannula or suction cannula. So by doing it 2 or 3 times, you can just irrigate the joint. Things will be very clear. If some hidden loose bodies are there, they can come up in front of you. So that will help. So irrigate the joint before going for. So next is that you have to examine the important landmarks. I have already told what are the points by which rhythm we are going for this diagnostic arthroscopy in the knee joint. But I will again repeat the important landmarks, because these are important, and how to hold the scope and where should be your light source. You have to understand that. So under surface of the patella is very important to look for any chondromalastic change. So it should be done. So the position of the knee in case is extended, camera position is horizontal, and light source should be downward, so that you can have a look into the superior or upper part. So look for any damage to the articular cartilage and medial and lateral facet of the patella. So examining both facet of the patella is very, very important. Next is the making an anteromedial portal. So once you are from the superior area, so you have examined all the medial lateral gutter, you have come to the medial joint space, you have come to the notch. Now you have to make another portal. That portal is a working portal, because your shaver will go in from that portal, your punch will go in from that portal, your probe will go in from that portal. So that is a working portal. So it should be done under direct visualization. In 90-degree flexion, it is usually done. Camera position is horizontal. Light source is facing laterally, so that you can have a vision medially. So in the picture middle, you can see your light source is facing laterally, so you can have a visualization in the medially. Suppose in this case your light source is vertically, you will only look into the downwards, and you will only look into the tibial condyle, and you will search for the needle where it is coming, and you will not able to see the needle. So that is the most common mistakes our juniors do. So your light source should be on the right side. That thing you have to do, so that you can have a clear visualization of the anterior horn of the medial meniscus. You can see that your needle is coming just above that. From the right picture, you can see the needle is coming from just above to that. That thing you have to be very sure. Second is that use whiteboard needle for direct, followed by skin incision and preparation of portal with trocar, and try to avoid damage to the meniscus while again you are putting your skin incision. That is why. So in this case, I'll advise that first you cut the skin very gently, then you cut the capsule very gently, and before putting your any working instrument, you just put your blunt trocar in and try to make a maneuver by circulating it, so that you have a good entry and there is no entrapment of soft tissue in between, whether you are trying to put any of your instrument for working. Okay, that is also an easy trick, so that it could be very useful. Next, you come to you have to look for the medial compartment. So again, as I already told you, that it should be seen in flexion, and sometimes you need to put a valgus force to open up the medial compartment, because otherwise you can't see the posterior horn of the medial meniscus. So to see the posterior horn of the medial meniscus, or if there has been a tear in the undersurface of the posterior horn of the medial meniscus, you need to put a valgus stress. Then only you can see. So your camera should be at horizontal. Light source should face laterally, because you are again looking at the medial part of the joint. So your light source should be laterally and look for meniscal tear, any osteochondral defect. So valgus force should be there to help you. Then you come in the middle area of the joint in the notch area, and it is usually seen in flexion. Camera is horizontal. Either you can keep the leg over the bed, or you can hang the leg, but it is seen in flexion. Camera should be in the horizontal position, light source facing downwards, so you have a broader visualization of the notch. So your light source is downwards, so you can see. But in this area, again, you can rotate your light source to look at different part of the joint or different part of the notch. So if you want to look at the lateral femoral condyle, the medial surface of the lateral femoral condyle, to see for the footprint of your ACL, femoral footprint, then you have to change the light source toward the medial side. Because if you change the light source to the medial side, then you can have a vision towards the lateral side. So by rotating the light source in the notch area, you can see different area. By at this point, now you have to use your shaver to clean all the fat and other things, so that you can delineate clearly the insertion points of all the ligaments and the meniscus. And now you have to probe all the ligaments and pull and check for their integrity. Is done usually in figure of 4 position, lateral compartment, and before doing that, it is recommended that you park your probe between the ACL and lateral femoral condyle to avoid loss of orientation. So you can park your probe first, then just you can go and trace your probe there. So camera should be perpendicular to the tibial plateau. You can see camera should be perpendicular to the tibial plateau. Light source facing inferior-medially. Light source should be inferior-medially, and look for lateral meniscus, osteochondral defect, and osteophytes. So if light source is inferior-medially, then only you can look the superolateral structures. That means the meniscus will be superolateral in this area. Because once your leg is figure of 4, the lateral meniscus will be here. So that is why you can go for that. Sometimes there may be some problem in visualization. That is what we are actually telling you, to put a vertical incision in the anterolateral portal before making. Because sometimes inadvertently we can do a high portal, or we can do a low visualization portal. So if we do a high visualization portal, there will be difficult to visualize the posterior compartment or posterior horn of the medial meniscus. You will be unable to see that. In that case, you can change the portal to a lower one, and you will be able to see that. And if you put it too low, then there may be chances of injuring the meniscus, anterior horn, and your scope may be stuck between the femoral condyle, the roundish portion of the femoral condyle. So that is why you have to put it in a exactly proper location. So your vertical incision will give you a scope to change your portal position. That is why the vertical incision is important. So next important thing to discuss is the triangulation in arthroscopy. That is very, very important. Everyone sees that triangulation is important. So basically it is a psychomotor skill. You need to develop it by repeated practice, so that your brain can actually imagine and give you an image actually where your hands are, because this arthroscope and working instruments are your extended hands, and they should act in synergy so that you can do your procedure. So triangulation is actually sometimes when you put our scope, then when we put our working instrument, initially we don't able to find where is actually the instrument. So that is the skill of triangulation, and you need to practice it regularly to make a habit of it. And the main trick of achieving a triangulation is that first you need to try to touch the instrument. So if your scope is already inside a joint, if you are in the notch area, try to park your scope into the notch area, because that is the most spacious area into the joint. Then try to put any instrument to the notch area. So first rule should be go into the notch area and try to touch the scope with your instrument first. So once you touch your scope with your instrument, then gradually move your instrument in front of your scope. Then move both scope and the instrument to your desired area of your knee. So try to practice like this way initially, then it will be easier for you, and reduce the angle between the instrument and scope, so that you should be very close with your two hands rather than very apart with your two. If you are very apart with your two hands, then it will be very difficult to do with your arthroscope. Rather than you should be try to be very close and try to reduce the angle between two. So these are all the basic tips and tricks in basic arthroscopy, how we can acquire the skill. So if there is any question till now, we can take that. Otherwise, I think we can go to the next talk, that is the basics of arthroscopy. So if there is any question, so I can take that now, or we can take it later on.
Still now there is no question. If there is any question, please put your question in the chat box.
So I think we'll move to the next
Yeah,
talk.
yeah, yes, sir, yes.
Okay, so that is the basics of arthroscopy, ACL reconstruction, basic important anatomical and technical consideration you should understand before you are going for a ACL reconstruction. So these are the important issues in the anatomy and positioning of the tunnels, because in case of ACL reconstruction, the placement of the tunnel and choosing your graft is the two main important things which is actually determine your success of the procedure. So you have to make the tunnels in proper positions, and you have to choose a proper graft for your proper patient. That is important, because graft fixation, screw fixation, and putting an endo button and other things is a technical thing. And I think most of the people can learn that thing. But what is important is that this positioning of the tunnel is most important, and most of the people are wrong in positioning of the tunnel. So before going into that, you need to understand and consider the anatomy of that. ACL has got two bundles, and consisting of this anteromedial and posterolateral bundles. So actually, it's like a ribbon-like ligament, and we are trying to going for a single bundle ACL reconstruction with that. And this is the primary resistance of anterior tibial translation. That is all known to you. So if you can understand the anatomical picture, that is of two bundles are there. One is anteromedial and one is posterolateral. And the thickness, length of the ACL ranges from 31 to 38 millimeter, and it usually 10 to 12 millimeter in width. And AM bundle average measures 6 to 7, while PL bundle is 5 to 6. So it is 10 to 12 millimeter width normally. And one important thing is that in extension, the anteromedial bundle is loose, whereas the posteromedial bundle is tight. Posterolateral bundle is tight, whereas in flexion, the anteromedial bundle becomes tight. So these two bundles act differently. So how these two different bundles can make up, we can make up by with one single graft. That is our challenge. That is why we need to put it in proper exact position to make functions of both of these bundles. So if you can consider the strength of the ACL, because it is important to know, because while we are choosing our graft, we should try to recreate it. We should try to recreate the structural properties of the ACL, or as also the functional properties of the ACL. Then only we can have exact recreation of a ACL reconstruction. So biology of injured ACL is also important, because sometimes there are few patients which MRI report comes as a partial ACL tear. Some of these patients may heal, some of these patients don't heal. So why this happens? Because if you can see this image on the right side, this ACL has got a thin vascularized envelope. This is a synovial membrane, this is intrasynovial. So that is when till the synovial membrane is intact, these collected blood in case of an injury or in case of partial injury, they can organize in a fibrin meshwork, and they can promote, they can actually bring the cytokines and growth factors which actually helps in healing. Whereas in case of some partial tear, while this sheath is torn, this healing is not going to happen because presence of the synovial fluid. So that is why these partial ACL injuries, they are behave unpredictably. Some heal, some don't heal. It depends on your clinical examination and understanding. So you can see in the image above that some ligament injuries, partial injuries, there are intrasubstantial injuries, whereas the covering is intact. Some injuries are intrasubstantial injuries, and also the covering is torn. So these are not going to heal, and with time this will be a full tear, or this will be a non-functional or elongated ACL, and ACL reconstruction may have to do. And in case of complete injury, you have to do. So that is why important that in partial tear ACL, where the synovial lining is disrupted, healing is very, very unlikely. Here you can see there is a only the posterolateral bundle is torn, whereas the anteromedial bundle is intact. So depending on the laxity, depending on our clinical findings, we can go with this patient. See the MRI image, the synovial membrane, that is a dark black color. The consistency of the ligament is there. It is almost maintained, but there is some intrasubstance injury and the synovial line is not maintained. So that ACL may not be going to be helpful for us. So there has been a debate for autografts and allografts. Still now it has been proved that autografts are much better in case of ACL due to many reasons. So there are options for autograft in ACL is whether we can go for a bone patellar tendon bone graft, or we can go for a quadruple semitendinosus and gracilis graft, which is gold standards nowadays. We can have two other options like quadriceps and peroneus longus. So bone patellar bone tendon grafts is a usually 8 to 11 millimeter wide graft taken from the central third of the patellar tendon, where it is adjacent patellar and tibial bone blocks. So one of the benefit of this is that they are attached with bone blocks. So these bone blocks are actually help in their healing. So it was a popular bone graft because of the high ultimate tensile load, which is closest to our ACL, normal native ACL. But there is a chances of stiffness in the knee and possibility of rigid fixation which is attached. So the benefit of is that this bony blocks helps in the healing, but there is also disadvantage. There is donor side morbidity is high. Sometimes there is a chances of patellar fractures, and sometimes in case of very low short statured female, this already the patellar tendon is very small, so you can't take that much of graft from that area. Whereas hamstring is a gold standard, so I think everybody is knowing about this. So we take a semitendinosus and sometimes gracilis also, and we quadruple it and we use it. So this is the most easiest available and most commonly available. So it becomes comes around 8 to 10. Some Indian average is around 8. It usually comes and we take it to quadruple, and it is the as we take it quadruple, folded multiple times, also provides a multiple banded replacement graft and maybe better approximate the function of two bundle ACL. So as you take it in quadruple manner, so it is betterly recreate the two bundle ACL. That is why it has become more and more popular nowadays. So you can see how a graft is taken, but the consensus and the most commonest questions being asked in every forum is that what is the least diameter of graft you can take? So that is what it's very important to have at least 8 millimeter graft for male patients and at least 7 millimeter for female patients. Some surgeons can settle up to 7.5 millimeter, but and length should be at least 280 millimeter, because that will be good enough, adequate enough. We'll have a good fixation in the proximal tibial part. Otherwise, it will be a difficult one. Next option is the quadriceps tendon is another very good graft, but usually you don't use for a primary ACL reconstruction. But in case of a revision ACL scenario or a failure ACL scenario, when you have to take it, or when already the semiti and gracilis grafts are inadequate, in that scenario you can take a quad tendon graft. So this is chart showing that this quadruple hamstring graft has got almost double strength, tensile strength compared to our native ACL. So even as we are putting, but our native ACL is around 10 to 12 millimeter in diameter, whereas quad tendon can be of 8 millimeter of diameter also. But as it provides more tensile strength, it can recreate our ACL reconstruction. So next important is the graft placement. Where should we place the graft? So it should be on the isometric placement, because there is when we two bundle ligament and we are trying to recreate with one single graft. So it should be placed isometrically. That is what important points we'll discuss on the placement of the graft is that should be in the posterior portion of the ACL tibial insertion site near the PL bundle position for best reproduction of the function in the intact ACL in a single bundle. So in a single bundle reconstruction, we will actually try to recreate the posterolateral bundle. That will actually best recreate the intercruciate ligament function with a single bundle. That is important. So for the tunnels, we try to be most anatomical, deemed anatomical as much as possible. So you have to look for the footprint in the femur, footprint in the tibia if it is present. So in case of fresh fractures, fresh injuries, the footprint may be present. But if it is old injury, the footprint may not be present. So in that scenario, you have to take consideration of other landmarks. For tibial tunnel placement, there are the different landmarks are there. So one of the important landmarks are, it should be anterior to posterior cruciate ligament 5 to 6 millimeter. It should be should not impinge on the graft. It should posterior edge of the anterior horn of the lateral meniscus. So you can draw a line from the posterior horn of the posterior anterior edge of the posterior lateral meniscus, and you should be have on the slope of the medial tibial spine. So all these anatomical landmarks you need to consider. And for having a proper length in that tibial tunnel, we actually take our jig into 50 to 55-degree angulation, and we start from approximately 1 centimeter proximal to the pes lancerinus insertion site and 1.5 centimeter medial to the tibial tubercle. So these two landmarks are there. We'll start drilling from that, and we'll keep our jig notch in the intra-articular area that we already discussed. So this is the area. 2-3 landmarks are there. We should be front to the posterior cruciate ligament. We should draw a line from the lateral meniscus, anterior horn of the lateral meniscus, and this is the slope of the medial tibial spine. And if there is a presence of remnant of the ACL, you can go at the center of the ACL remnant. So by this, you can determine the tibial tunnel position. So this is where you can actually should come. This is the medial lateral meniscus area. This is the PCL which is shown. This is the medial tibial spine, and this is most probably the center area. So you should have come to this area. So every aspect and every point you should double check, and you should make sure that you are actually coming to the exact point. So this is a tibial drilling jig, so you can center it. So this is just a representation of Siam image. I have just put it for your clear understanding, so that this is the intraspinous area where you can put your jig and then you can drill. This is usually done in 55-degree to 60-degree angulation. Next, for the femoral tunnel is that you all know the notch area we can divide in different clocks. So you should try to be around between 9 to 10 and 2 to 3. That is most important. That is the area of insertion. So there are available guides which can help you to put the femoral tunnel, but also you can use by your eyeballing method with your open hand technique, so that you should at least leave a 3 millimeter posterior wall, and you should be away from the cartilage margin in the proximal part of the femur, in the lateral femoral condyle, and you should be behind the resident ridge. So all these 3 landmarks you should understand. So you can understand the notch anatomy. You should try to be at the 11 o'clock or at the 2 o'clock. You should be 3 millimeter posterior femoral bone should be left. You should be away from the anterior cartilage margin of the lateral femoral condyle. You should be posterior to the resident ridge. So these 3-4 landmarks are there, and there are 2 methods. Initially we used to do by transtibial, but we don't do it now. So this anatomical or transportal is like we go through this anteromedial portal, and we have this commercially available jig which will help to drill the femoral tunnel. So this transportal technique drilling is done in 120 degree of knee flexion, whereas in transtibial it is done in 90 degree of knee flexion. So you can see on the image right side that is drilling in done in 120 degree, and it is from the anteromedial portal. So once you have you corrected your both the portals, and once you have passed your graft and fixed it, then you have to make sure by your double check whether you have put it in the right position or not by checking this triangle. So if your graft is in right position and properly tensioned, then you can look for a triangle which is formed between the graft which you have put. This is the graft, the intercondylar roof or intercondylar roof area, and the upper half of the posterior cruciate ligament. So there should be a formation of a triangular space between the graft, PCL, and the intercondylar notch area. So by looking at this, you can make sure that you have put it in right position. So for a successful ACL reconstruction, you have to understand that it consists of 2 bundles, and you have to understand the function of both the bundles, and we are trying to recreate with one graft the function of both the bundles, but functionally we try to recreate the PL bundle. Quadruple semi-T gracilis is the most popular gold standard nowadays because of less donor side morbidity. Preferably at least 8 millimeter graft should be there for male and 7 for female. Graft length should be at least 280. For single bundle reconstruction, we try to recreate PL bundle, already told. For anatomical double bundle reconstruction, base is to follow the original footprint, but not commonly addressed nowadays. Avoid impingement of the graft with the notch and PCL and confirms it by triangle method. That triangle we have already shown. Final fixation of the graft in tibia should be done around 30 degree of knee flexion and 15 degree of external rotation with a posterior draw stress. So those are the important points. Thank you. So I think if there is any questions, we can take that.
If you have
or
any, if you have any question, you can put in your chat box.
yes,
Still now, sir, there is one appreciation has come from Dr. Saurabh Chatterjee.
okay.
The lovely explanation by viewing of techniques.
Hmm.
So I think he's your student. He has seen and he has given that comments,
Okay,
Dr.
okay.
Saurabh Chatterjee. And if you have any questions, so you can put that question in the chat box, so we can take with Dr. Karmakar.
Yes, and by the meantime, we can wait for some time, or we can show them some videos of techniques.
Yeah, yeah, sir. You can show the videos.
Okay, so
Uh,
that would be interesting for some.
yeah.
So what actually till now we have
Sir, there is a
explained.
question has come
Okay,
from Dr. Sergil. Which bundle is reconstructed in PCL, AM or PL?
PCL,
Uh, sorry, AL or PM?
PCL. Okay.
Hmm.
No, actually the thing is that for ACL reconstruction, these two bundles are have different actions in knee flexion and extension. That is why we are actually going for a single bundle reconstruction. In that case, it has seen that most of the anterior translation is by the PL. That is why functionally and positionally it has seen that if we recreate the PL bundle with our graft, it actually does the job of ACL, most job of the ACL. That is why PL bundle. But in case of a, because ACL has got a two components, it's got a rotatory component also, and also got an anterior posterior stability component. Both these components. That is why two bundle structure, two bundle anatomy and recreation is important for ACL. But rather than PCL, if you consider the PCL or posterior cruciate ligament, it is a central structure or vertical structure. So only thing important of the PCL is that it is restrained to the posterior translation of the tibia. So PCL is being a central and vertical structure. There is no such concept of putting any specific bundle for the PCL. So in case of PCL, we just try to create the exact location or insertion point and we make it tight because there is no rotatory component or rotatory stability component for the PCL. There is only anterior posterior stability of the PCL. That is why this much of importance is not given to PCL, but it is given to ACL. And that is why double bundle ACL has become still famous. Double bundle PCL is there, but it is not made compulsory, or it is out of fashion nowadays, because it has been seen that double bundle PCL and single PCL has got same results, rather than this single bundle PCL has got better stability in preventing the posterior translation of this tibia.
Yes, and the next question has come from Dr. Ayon Ghosh. That is, sometimes the notch is very shallow, and shall we cut the cartilage in anterior part of notch to minimize notching?
Yes. So that is a very good question. So we just discussed briefly. So when in the notch area, especially you have to be very careful in some female patients, in young female patients with a short stature, these knots are really very narrow. And sometimes the shape of the notch is also very abnormal, like V-shaped. So likely once you understand, this notch should be like U-shaped. So it has to be like U-shaped. But once it is not U-shaped, sometimes it becomes V-shaped. So if it is V-shaped, we have to cut the anterior part of the lateral femoral condyle in the cartilage and subchondral area to make it a U. So if it is a V, you have to make it a U. And only you try to cut the anterior part in the lateral femoral condyle, because both way it will help. If you cut the anterior part of the lateral femoral condyle, it will help in prevent notching in lateral notching also, and also notching in extension also. So in both way it will help. So you have to look and you have to make sure that your notch is wide enough and there is no notching after you reconstruct your ACL. But it should be done before putting your graft.
Sir, there is a question, there is a request, in fact, from Dr. Saurabh Chatterjee. If possible, please show us the pearl side once more.
Which one?
Pearl side.
Last slide. Okay, okay.
Okay.
Okay, sure, sure. I'll show it. By that time, is there any other questions so you can take?
Yeah, definitely, sir. So if any other question, please put in the chat box. We'll take all the questions.
Okay. So I think I'll share the screen now.
Right, sir.
Okay. So the pearls of the ACL reconstruction is that, see, it has got both the bundles, and you have to understand which bundle is tight in flexion. So AM bundle is tight in flexion, and PL bundle is tight in extension. That is why we're trying to give it the PL bundle, because in it is important that you give the stability to the knee joint. Quadruple semi-T and gracile is the most popular graft, followed by BTV. BTB has been popular in long time back. It has got many benefits, but one of the important things that it has got very high morbidity in the donor side, and the taking up the BTB is also very much technical. So sometimes it can lead to arthrogenic patella fracture. That is why we are not using it nowadays. Preferably, at least you should try to achieve 8 millimeter for a male patient and 7 millimeter for female patient. Some surgeons stick to 7.5 for female and 8.5 for male. It again, for an athlete or high demanding person, I think you should try to achieve for that. But for relatively common people, it should be 8 and 7 should be good enough. And length adequate should be at least 280. 270, 275 can also do, but the length in the graft in the tibial tunnel will be less. For single bundle reconstruction, we're trying to recreate the PL bundle. That means PL bundle insertion points. That the point means is that we try to recreate the PL bundle insertion points, but it is definitely thicker than the PL bundle, so it actually does the job done. And that is why it is more posterior near to the PCL insertion site. For anatomical double bundle reconstruction basis to follow the original footprint, both the footprints have to be followed, but as it is technically demanding and the benefit is not that much significant compared to a single bundle reconstruction. So nowadays, all surgeons have shifted to a single bundle reconstruction. And avoid impingement of the graft with the notch, as Owen already discussed. We should try to avoid with the notch, both in the superior part and also in the lateral part. So superolateral notching should be avoided. Two tricks for this is that you try to see the notch first. If there is a narrow notch, you can broaden that up, or you just place your tibial tunnel slightly medial. That means rather than keeping it exactly center between the two spines, you just keep it on the slope of the medial tibial spine, so that it also minimizes the chances of lateral notching. And you have to check for this triangle, which I already shown in the image. So final fixation of the graft is done in 30-degree flexion and 15-degree external rotation. Nowadays, some all of the surgeons, they don't agree with this point. They say neutral is also fine, but you can also go for external rotation also and a posterior rotation. So this is the part take home message for this ACL reconstruction.
Sir, Dr. Oyon Ghosh, he make
Yes.
a question to femoral tunnel horizontal. Is it better to use accessory medial portal than doing it from AM portal? Although we are trained in AM portal only.
Yes. So I'll say that this is a trick where I'll show you another slide, and I think that will help to understand everybody what is the changes, two changes I do in my practice to take these points. So I'll share my slide again. So yes. So you can see on the left side, it is the standard portals pictures are there, pictorial. So you can see the anteromedial portal, how much it is close to the patellar tendon. Almost it is close to the patellar tendon. Why it is given? Because this is the working. So any work in your notch, like cleaning, shaving, taking up of the fat and other things are very easy if you be very close. But for a ACL reconstruction, or where I know that I need to go for a ACL reconstruction, you see my patient or my image on the right side is that I have done the anterolateral portal is more towards the patellar tendon. That means the visualization will be better in the notch area. Whereas my anteromedial portal is much away from the patellar tendon compared to the pictorial image on the left side. So I have made already my anterolateral portal a bit far medial, anteromedial portal. So both way, because it will help me to put our femoral tunnel more horizontally. But if at intraoperatively I feel after flexing that I am not being able to go to the footprint exactly, and my trajectory is coming very inferiorly or very superiorly, then actually I may change and go for an accessory medial portal. But most of the time it is not required. I may have done one or two cases. Otherwise, I think also we have done many cases together. And in my was my PGT there. So we were sufficient enough to do it in a slightly medialized anteromedial portal, and we can actually reach the exact trajectory for the femoral tunnel. So, but if yes, if you can require it, you can do it. That is all what I can say.
Before taking any question, can we go for this video, Dr. Karmakar?
Yes, so few videos I'll show you, because these are so uh, yes. Again, it's not showing. I think I'll stop and start again.
Yeah.
But that time it was so.
I think it will slow after coming to the slide mode option.
Yes, but morning we tested, na?
Yeah, morning it is showing.
Was showing.
But that time it is in the slide mode option.
Okay, let me see. No, it is not showing. And sometime it shows, sometime it don't. Last day also it was meeting. Okay, so I'll show it in separate way. No matter. So first I'll show you the diagnostic impression of footprints. So this is the video where actually we are going for the diagnostic roundup, and actually the prepare the femoral footprint. So this is the medial meniscus. We are looking at the medial part of the joint and posterior part of the joint, and the notch area where we see that the ACL is injured and it is turned down. So we need to clear all this debris tissue here, because we need to clear the footprint. And once before we are going for the femoral tunnel, we need to clearly see the whole of the medial border, medial surface of the lateral femoral condyle. You have to understand, identify the residence ridge. You have to identify the posterior border of the lateral femoral condyle. Because as I told you, the guide for putting a femoral tunnel is that you have to keep at least 3 millimeter bone in the posterior part of the lateral femoral condyle. So when you are using a jig, it is fine. But if you are not using a jig and you are doing with eyeballing, you have to understand, look for the footprint. That is important. You have to be posterior to the resident ridge, another important. And you have to make, you have to keep a clear cut area of bone in the posterior femoral. So you can now see I am just going in between the PCL and the lateral femoral condyle, and this is the tibial footprint area in the insertion point of the ACL where I am cleaning all this. So in a old case, I'll clean all this, but in a fresh case, I'll try to preserve the stump as much as possible, whatever is there, because in a fresh case, there is chance of revascularization, but in a old case, there is no chance of revascularization. So if you can see this area, the black area between the femoral condyle and the PCL. So I have gone up to whole of the lateral femoral condyle up to the back. You need to clear all this thing before you go into put your area. So this is the area you need to clear, and once you clear all this, you can see the footprint of the ACL there. Once I clear the image, you can see. So the whitish structures are coming. You can see the whole of the femoral condyle and the footprint just center to this. So another video I'll show. So this is the footprint area, and putting the femoral tunnel, that is also will help you to understand how we are actually using these anatomical landmarks for putting the femoral tunnel. So this is the, after we clean it, we look, see the area. So once we clean it, we look into the face, end face on the lateral femoral condyle. So this is the end face of the lateral femur. So these whitish structures, whitish fimbriated structures are actually the remnant of the ACL. So what I use a 4.5 drill bit to put over the remnant of the area. So 4.5 drill bit will actually replicate my ACL graft, and in between on the center of that area, I will go through with my pin. So here I am trying to locate the center of the ACL footprint area. So this whitish is the center of the ACL footprint. Here some is the resident ridge, some over here. So I have to be at the posterior. Through that I actually drill. I put my pin in, and over that I drill the 4.5 drill bit. So by 3 or 4 methods are there, you need to confirm before you actually go in and drill it. Okay, so see this image. Actually, this whitish area is the center of the ACL footprint. So I am just exactly center to this. So this whitish area, some fimbriated tissues are there. I think most of the people can correlate. This is the footprint of the ACL, and I am actually centered to this. And I am actually good oblique. With the trajectory, I can understand that I'm enough oblique. I don't need to go for a far medial, anteromedial, portal, something like that. And once my bit pin come out, it should be at the level of the femur bone. It should not be very superior. Then I need to change it. Otherwise, I am good enough. See, my drilling is going through is exactly to the already footprint, whichever is there. See, my drilling is going through exactly on the footprint. So this is what you should aim for, exactly in the center of the femoral footprint, because sometimes your jig may vary with your company. Sometimes these people will carry only one size of the jig. So you have to use that jig for your graft, for 8, for 9, for 6, whatever graft you have to use that only one jig also. So I think try to go by this anatomical landmark, try to make your own understanding, own landmarks, and try to recreate that. That will be most important thing. And always double check, double cross in every step before you finalize doing it. That's all. So this is a femoral tunnel. Any other question has come by this time? Or?
No, sir. Still no question is there.
So we'll go by this. So this has been the femoral tunnel, and what was I was discussing for how to prevent the notching in the tibial tunnel. That will I'll show that in case of a tibial tunnel area, we also need to slightly on the medial side, so that we can avoid the notching on the lateral femoral condyle. So this is the area. Once we are trying to drill the tibial tunnel, if you can understand, my jig is actually sitting on the medial spine. This is the exact medial spine what we are looking at. So my jig is exactly sitting on the medial spine area. So this is the lateral spine, this is the medial spine. My jig is exactly sitting on the medial spine area. So this is the lateral spine. Right, it's not. Yes. So this is the lateral spine, and this is the medial tibial spine. So my jig is exactly. So this is the medial tibial spine. So it is a lateral tibial spine, and this is the lateral meniscus anterior horn. If you can draw the lateral meniscus, it is actually coming somewhat here. So rather than being exactly in the center, I just slightly go medially. I graze the medial tibial spine. That is the trick I always try to do, and many times, especially in case of a small notch, it helps me to avoid the notching in the lateral surface. So next, if I go, so if I go by this, now what I will do in this type of elbow jig, I slightly slowly drill it. I don't push it too much. So once the pin is out, I just stop and I try to hold the pin. I hammer the pin slightly. So I take out the jig and I use my hammer to put it in. So now I'll hammer it, just slightly hammer it and hold it. And after that holding that, I drill it. So next you can see, once I drill it, I use my shaver blade to clear my path so that it don't hinder in passing my graft. So that is important. Then I take out the suture through this. So once my suture is out, you can see the proposed trajectory of the ligament. So in the last view, you can see once it is the proposed trajectory of my ligament. So see, this suture is the proposed trajectory of my ligament. So it is coming from back, so it is way back from the cartilage area. So I think most we are not going to notching in this case. That needs to be clear very fine. And finally, I think we'll show you the screw placement and position of the leg when you are actually pushing the tibial screw, and that will I think we can stop with that because that is important. We have discussed theoretically, but the screw position for when we are actually putting the screw. So this is the position of a leg, which is actually hold. We are when we are drilling the femoral tunnel. This is 120 degree of flexion should be there. As I told you, 120 degree of flexion should be there for femoral tunnel drilling. And when we are pushing the tibial screw, this should be the position. Your knee should be 30 degree flexed, whether in neutral or 15 degree external rotation, and you should push a posterior drawer to fix it. And you should pull the graft with your opposite hand. That is the important message, I think so. So I think we have covered all of important aspects and tips and tricks for
Yes, sir.
with ACL. So if there is any more questions, we'll be happy to answer. Otherwise, I think we are done for today.
Uh,
Now I'll request Mr. Shishendu Mukherjee to give the vote of thanks.
Sir, first of all, Dr. Karmakar, thank you very much because near about from entire eastern zone means Bihar, Jharkhand, Odisha, Guwahati, Assam, all that place. There are 50 participants was there till now. Okay,
Okay.
and it would not be happen without you. It's a successful program only for you. So first of all, thanks to you that you are giving us time from your busy schedule. And I hardly thank each and every participants, every doctors to make today's CME more successful. In this lockdown period, we are just sitting at home and we are sharing the knowledge. In fact, we are discovering new things that is digital platform where we can share everything. So we give the name this platform that Beyond Boundaries. So this in this Beyond Boundaries, we welcome you all the time. And I hope that all the doctors, even Dr. Karmakar also, will come once again in this platform of Beyond Boundaries. And we will, in near future also, we will do this types of program, more program. We don't know when the lockdown will be over. Maybe 3rd May or it can go, we don't know. But we use this platform. And thank you once again to Dr. Karmakar for giving this from his busy schedule, and all the doctors, those who are participants from their busy schedule and make this CME more successful. Thank you very much from entire group of Okhad Marine and platform from Beyond Boundaries. Thanks a lot.
Thank you, sir.
Thank you, sir.
Thank you so much. Thank you, everyone, all participants. And I think this is the best way we can enjoy the lockdown. We can utilize the time so that we can continue with that. And
Sir,
thank
in
you.
fact, there is Dr. Saurabh Chatterjee has given us a request. Please arrange similar session for PCL and meniscal pathologies.
Okay, sure.
Pathologies.
Definitely we will. So whenever we plan our next session, will be on PCL and meniscus.
Thank you very much. Thank you very much, Dr.
Thank you. And be all safe and healthy. Goodbye.
Kamar.
Thank you, sir.
Stay at home.